that this is not something else. This is future allopathy or conventional medicine. Dr. Vivek also runs some programs and trains people on hormone therapies. If anybody is interested in doing hormones, I think you cannot do it right till you have attended Dr. Vivek's programs. Of course, he works very, very closely with Dr. Mahesh Jayaraman on infertility cases, and he has some amazing case reports on that. Another thing I think Dr. Vivek has contributed, at least in my communication, is it's Dr. Vivek who first time told me that thyroid is the CEO of human body. Right, Dr. Vivek?
Absolutely.
Great. And then when I looked back and started thinking, I realized, wow, how did I not think about this? Now, so from there, from my interest in thyroid, from learning from everyday new senses and to following what research is saying today, I think, thank you, Dr. Vivek, for contributing so much in my practice and in everybody else's practice and making functional medicine reach where it is today. So with that, I welcome Dr. Vivek to speak on especially role of T3, right? And what are Dr. Vivek's views on thyroid disorders and futuristic or right way to manage it in today's world, in today's environment, with the type of symptoms today's patients are presenting us with. Over to you, Dr. Vivek.
All right. So thank you, Dr. Preeti. Am I audible?
Yes, loud
All right. And I think that's the most generous introduction I've ever had, but it came right from the heart. So I feel good about that.
It came right from the heart, Dr. Vivek, and every word I said, I mean it. Thank you very much.
That's wonderful to hear from one of my, well, good, perhaps my best student. Coming back to this, Preeti, I have 20 minutes of presentation, 10 minutes for questions, right?
Yes.
All right. So right at the outset, are you going to, I've sent my PPT, I can present from my side, or are you going to present it from your side?
You can present it,
From my
Dr.
side.
Vivek. Yes.
All right. So my first thing is, of course, a declaration of financial interest. And I want to make it clear that, yes, I have financial interest in what I'm going to say, because I run a compounding pharmacy that supports the compounded medicines that is required for practice, and a lot of it has to do with what I say. So having declared my financial interest, now let me get into academics, pure academics. Before I even put my first slide, it's important to know that the word, what Preeti said, whatever we do should not be considered as alternative medicine, should not be considered something different. It is evidence-based medicine. It is modern scientific medicine. And we use that phrase that Preeti says, for those who understand Hindi very well, tera hi tota kehta hai, that the journals are saying the same thing. So if I have to support what I say, you don't have to believe what I say. I will provide evidence based on the evidence that you are providing me, more than evidence that I have provided. My evidence is there in my clinical practice. I don't need somebody to tell me about that. All of you should also inculcate that habit. The habit should be that, yes, we know this is true. We know it is true, but what is the evidence that supports us? And what's the evidence that also goes against it? You should know both. So this is a topic, and I've narrowed it down to T3. The reason T3 is most of us know about T4. So I don't want to talk about what T4 does and T3 does. But in order to understand T3, and I'm going to make one bold statement here, that if you do not incorporate T3 prescription in your practice, you are doing a great disservice. It's not complete. T3, one way or the other, it does not matter whether you use whether you use porcine, bovine, or compounded. I'm not here to support or refute anything that's any claims made by others. I'm saying that you have to understand why the T3, and then you'll understand why actually every case deserves T3. It's only that our mindset we have to change, but it's finally the patient's choice. So this is most important, that if the patient does not understand, is not there, well, then leave them alone. But now let me start my presentation and listen carefully to the evidence. And I'm focusing only on T3. So I'm going to share my presentation. Here we go. I think I'm okay here. Can you guys, are you seeing the presentation?
Yes, yes.
All right. So, okay, there we go. So these are, of course, just visual aids. This part, now all of you, this is very important to spend time and understand. Now, this looks like a very complex, plenty of noise on this slide, but this is the kind of slide I keep building on. It becomes more and more complex, more and more comprehensive. So just to explain to you fundamentals, and fundas are most important, without which you can't understand what I'm going to say. So thyroid produces two types, and these are all under ideal circumstances. Okay, we'll look at non-ideal conditions. 80% of that is T4, 20% of that is T3. T3 is the active form, maybe 3 times, 4 times, maybe 10 times more active than T4. So finally, we want more of T3 in our tissues, and perhaps even in the blood. But finally, more tissues should it should give us more T3. T3 is the form of thyroid that we want. A lot of this conversion happens also in the periphery. In the brain, it happens in the muscles, it happens in the liver and kidneys. So remember that this is happening, and therefore don't think that you can micromanage the entire process. Then the other part of it is that when the T4 goes to the periphery, 80% of that converts to T3. But very important, this is the most important part, 20% goes through a different pathway, enzymes being the same, D1, D2, deiodinase enzyme, and D1 and D3 goes to reverse T3. Now, reverse T3 is, if you understand reverse T3, you will understand why our entire management of thyroid that we do in conventional mainstream medicine is completely wrong, because we do not, this is a very unique hormone, a very unique drug also, if you may use the word drug for it, that it has something which is an isomer, which is a mirror image and is inert. Not only is it inert, it actually blocks the receptors and doesn't allow T3 to do its job. That explains a lot of things, and this is very unique. I can't think of a single hormone that has this kind of a unique combination, and that's why I call it the CEO, because the CEO is handles everything. Executive officer looks at the operations, looks at the negatives and the positives. So that is important. And once you got the RT3, the RT3 is very greedy. Not only does it not block the T3, it inhibits the enzyme that converts the T4 into T3. So it is even blocking its conversion. It's blocking it. It is fighting it tooth and nail, wants to actually destroy, just dominate the T3. So once you understand that, you have to look at what is it in practice or in the disease process that creates more RT3. So if you have more RT3, you have a suboptimal management of a thyroid. You keep wondering, I'm giving good doses, I'm giving T4, I'm giving, even I'm happy with the T3, but it doesn't seem to be working. And one of the commonest reason of more RT3, of having too much of reverse T3, and I'll come to that first, is too much of T4. If you give T4 medication, if you keep increasing T4 medication, as we see in clinical practice, it'll keep increasing, and the reverse T3 goes up. So at some point of time, the T4 gets converted to T3, you have the effect, and then it plateaus and then starts falling. And then you wonder, I've increased the dose for this patient, but actually the patient is doing much worse. That's because you're generating more and more RT3. And if you do measure, and believe me, you can't always be dependent. I mean, the labs are not so accurate, but let's say you do measure the RT3, you'll find that's true. And I'll show some of the studies that show that. So among other things, you can see that vitamin D deficiency, anti-TPO antibodies, ferritin deficiency, estrogen dominance. So practically there is anything under the sun or under the moon will actually cause more of RT3. So keep that in mind, that environment is working against you. However, on the other hand, if you have iodine, if you have vitamin B12, B2, B6, vitamin A, selenium, zinc, as I just heard about some formulations that have these combinations, you can get more of T3. Now, don't worry about T3, because even a little bit of T3 is good enough as long as you handle the opposition. Okay, so very often in politics also, it's not a question of actually doing well yourself. It's how you handle the opposition. How do you handle the reverse T3? Of course, part of that reverse T3 both gets converted into T2 at this point of time. That doesn't have much significance. I won't focus on that. Now, just to give you an idea, we expect T4 to be converted to T3. Either T4 made by your own thyroids or T4 that is coming from outside. Now, if you look at all these, alcohol, smoking, heavy metals, chemotherapy, radiation, nutritional deficiencies, excess of iodine, sometimes you have to be careful with iodine. Do not push the iodine too far. Kidney disease, low progesterone, testosterone, deprivation of sleep. Now, I look at that and I say, look, I may have 6 to 8 of these factors myself. and everybody will have these. So all these, and there's a phenomenon called ubiquitination. That is, that itself internally does causes the reduces the conversion and genetic defects. So with all this put together, finally, you know that whatever you do, your T3 is never going to be the way you want it. You don't, and the reverse T3 is going to win as you go along. So you have to think of introducing T3 into your practice. Now, I'm not telling you should do it, but look at the evidence. If you feel the evidence is strong, you should do it. And there's a science to it. There's an art to it. I'll come to the art, but let me look at the science part. And most important, post-thyroidectomy. This is very important. Okay, let's say there's a lot of debate on should you use, should not use. What about a person that doesn't have a thyroid? That person can't produce even T4, needs both T3 and T4 because a lot of conversion happens within the thyroid itself, the T3 to T4 conversion. And then you're dependent only on peripheral conversion. So keep that in mind as a clinician that you have to do. And I do not like to use the word hypothyroidism because it means something quite different. There is something, just as people use the word hypogonadotrophic hypogonadism or terms for that. No, low T3 is a syndrome. So let's just say low testo syndrome. The terminology that we should be using is that we have a low T3 syndrome, which can have a normal TSH, a normal T4, or it can be normal to low normal, and low T3, and the symptoms. So finally, all the symptoms of hypothyroidism is there. So therefore, if you understand that cases of hypothyroidism, if you look through the different glass or looking glass and look at it as a low T3 syndrome, your focus will be on the T3, and then your clinical practice will make a lot of sense to you. Now, let's take some of the studies that will, as I said, Tera hi tota kehta hai. It's not my study. Look at this study over here. This is a very interesting study. Serum and cerebrocortical T4 and reverse T3. So they found, let's see how much of, if I give T4, what happens, how much of reverse T3 can be produced. So this, they looked at thyroidectomized rats, so they don't have any of the thyroids. Let's see what happens. Here we are at 0.2 micrograms per 100 grams of body weight, 0.2, 0.6, 1.6. So when they gave this 0.6, T4 was good, 8.6, but reverse T3 was 11. Okay, still not too bad. Once you increase the dose, 35 and almost equal reverse T3. And once they went to the higher dose, this happens when you keep increasing the dose of T4. This amount of T4 goes up to 57, but reverse T3 is 79, and reverse T3 is blocking your T3. So finally, you have good amount of T4. You say, I'm looking at good levels of T4, and some of them, I don't know, they don't even measure the free T3 or T3. They only measure T4 and TSH. And then look what happens in the cerebrocortical area. The difference is a lot more, 0.27 versus 3. And let me jump to the higher dose where only 3.85 nanograms per gram gets into the cerebrocortical area, and this reverse T3 is 96. So in the brain, you actually have a hypothyroidism where otherwise you don't have. So it's a brain hypothyroidism. So I'm going to quote from that study. Reverse T3 can cross the blood-brain barrier and inhibit D2 activity without altering circulation. Reverse T3 can produce a brain-specific hydrothyroid state. So this is important, that it's giving you a brain hypothyroidism. Rest of it seems normal. It can cause brain hypothyroidism without affecting other organs. And look at this. RT3 reduced brain T3 levels further and no effect on circulating T3, T4 levels, blood pressure, or body temperature. People with brain injuries are sometimes put into induced coma. This is similar. Studies suggest that RT3 could be used in a similar manner to induce a state of brain hypothyroidism or put a person into brain coma. So now you'll understand why the mental effects of this is high if you do not focus on the T3 or do not have ways to overcome the reverse T3. All right. There's another study that says serum reverse T3, total reverse T3 are slightly higher in hypothyroid patients who are treated with T4, but are congruent with a higher T4 concentrations in such individuals. This indicates peripheral T4 metabolism is an important source of circulating RT3. Values are high. So this is very important that you treat with T4, keep treating with T4, and you're creating a lot of reverse T3. And that's why I'm surprised that even the T4 works in some cases. So it will work, eventually it will not. So if you look at your clinical experience or anybody who's been through thyroid, it's almost the person thinks that, oh, I'm the only one. Everybody else is getting a benefit. My bad luck, my genetic makeup is not good. And therefore, somehow the thyroid T4 is not working on me. But if you look at the mechanism behind it, you will understand that almost in every case it's just that you accept because you don't know. It's what is called the myth of normal. There's a nice book which is called The Myth of Normal, that you think, oh, this is normal. This is what it can do. This is as good as it gets. Now let's see what happens to another part you need to understand. A lot of people ask me about this side effects. Oh my God, T3 is so potent. Maybe, it will cause thyrotoxicosis. It will cause cardiac arrhythmias. It will cause all kinds of side effects. So this is very important to understand. Though T4 is a lower, weaker form, its half-life is almost a week, which means that to completely wash out the T4 in case of an excess or toxicity, it takes about 45 days, 43 days or 45 days to wash it out. Whereas the beauty of T3 is any point you feel that, oh, it's going too much, there's an increase in the heart rate or palpitations or whatever symptoms, you just stop it. And in less than a day or in 2.5 days, it's completely washed out of your system. So it's actually safer than T3, which means that a Ferrari or a Mercedes is safer than a Maruti. Now, you might argue that Maruti goes slow and therefore it's safe, but actually it is the inbuilt, it's something which is more powerful, which often is safer. You'll understand that having more power doesn't make it unsafe. It actually makes it safer. Okay, so this is the one point that I want you to keep in mind when it comes to that. And also, please remember this half-life is very important. Remember this 1 week half-life versus 1 day half-life. Now I come back to this and I tell you where we are going wrong, because if you don't understand half-life, I'll just make one statement here, come back to it. When you look at the dosing of any chemical, any drug or anything in the body, if the half-life is 6 hours, you give it 6 hourly. If the half-life is 1 day, you give it once a day. Now, if T4 half-life is 1 week, why are we giving it on every day? Why are we giving it on a daily basis? So this is the first question we need to ask. That is completely wrong for a drug which is, or a drug that you're giving, which is a half-life of 1 week, that you're saying every morning, every daily dosing you need to give it. Completely unscientific. And I come to what the problem is, because that's where the cumulative toxicity or cumulative issue comes. So remember this. Go and open the pharmacy book. Go back to your original. Dosing of a particular drug depends on its half-life. And here we have a drug which is a half-life of 1 week, but we insist on giving it every day. But I'll show you how tera hi tota kehta hai. There are many studies that have argued against this, and I agree with them that you should be. See, here it is. Look at this study. Effect of daily versus weekly. So there's a person, they said, I'll give it weekly. Since elimination half-life of T4 is about 7 days, and its biological effect may last longer, giving it once a week seems the logical alternative. If not once a week, at least twice a week. So our first practice that we're doing wrong is giving it every day. Now, you talk to any of the doctors, they get very upset. They say, no, thyroid have to begin, T4 has to begin every day. You know what's saving us? Thank God there is reverse T3. If there was no reverse T3, these people would have reached toxicity in a matter of weeks. In conclusion, the present study shows that once weekly, T4 administration provides an alternative approach for treatment of hypothyroidism, especially in patients where compliance is a major issue. So look at the fundamental mistakes that we're making. And if I ask somebody, why the hell are we giving once a day, even the T4 when a half-life is 1 week? They have no answers. And we're just following it because my senior did it, their senior did it, and each generation is doing it. This is the first fallacy that we're doing it. And as I said, thank God for reverse T3. We haven't reached the toxicity as we would have otherwise. So remember this as a fundamental important funda that you should keep in mind. I'm not saying change your practice. I'm saying you're giving once a week. Question it. Am I doing the right thing? Why am I giving it once a week? Is it scientific? But if you ask me, if I were to prescribe thyroid today, I'm still prescribing once a week, because the moment I say once a day. If I say once a week, I'll get, my patient will show to a doctor, come back and say, what the hell is that guy doing? Luckily for me, I'm not doing much of T4 supplementation, so I'm quite happy. It's mainly my T3 that works. Combined replacement with T4 to T3 in proportion similar to dose secreted by normal rats. So when you're doing it rats, you go with rats. Human, you should. This is another thing. Don't use what's in rats or pigs or human. You don't extrapolate the same thing except for general principles in terms of medicines. Completely restored euthyroidism in thyroidectomized rats at a much lower dose of T4 than those needed to normalize T3 in most tissues when T4 was used alone. Okay, so there are these studies, and there are much more. I'm just taking representative studies. When people ask where are the studies, they're all out there. You have to spend some time and do the research. Combined therapy with this T3 and T4. What is the conclusion? Compared with T4 alone, replacement therapy with combination of T4 and T3 shows favorable changes in serum lipid profile, but a higher activation of bone resorption. Therefore, one of the important things we introduce in our protocol is the CTX. We also always keep an eye, especially in middle-aged and senior patients. that we always monitor the bone, because bone resorptions is not only a thyroid issue. You need to optimize vitamin D, you need to optimize progesterone, testosterone, all the other hormones. So be aware that, but in my experience, I have seen that it does not affect bone resorption, especially if you take the CTX. It might, in some cases, I see it, but usually they have some pre-existing condition. So if at all there's a downside, I would say it's not a cardiac issue. It's you need to protect the bone. And I think most functional medicine doctors, they even better than me, all of you out there, better than me, you know how to protect the bone with nutrition and other methods. So I will just tell you that don't. What I mean is, don't be unaware of potential downsides to any treatment that you're given. Now, effect of combination therapy, again, in this study where morning TSH levels were all not within the group, treated with...
Dr. Vivek, we will have
Yes.
to speed up. We only have 5 minutes. We have actually overshot the time.
Okay, so I'll go to this. I'll just go to all the studies that talk about use in infertility as I use. I use in all the studies that support use of pure T3. There I don't even bother to give T4. Male and female, male and female fertility. We quickly talk about for depression. So these are the 2 conditions where I use only T3, no T4. So, and my students know that very well. Coming back to augmenting and all these studies. So the studies are there. I'm just showing these studies as Preeti said. I highlight those areas so it's easy for you to read. And then we come to the antibody levels over there. And most important is you cannot handle antibodies very well unless you introduce some form of T3. So remember, T3, probiotics, they all come. And new preparations of sustained T3 have successfully passed the phase 1 clinical trial. So very soon you will find T3 becoming even in mainstream medicine. Now, societies are arguing over each other. Luckily for us, what happens is that they said, no, we don't validate it. ATS says we do. AA said, no, we don't agree with you. Let's not allow people to use T3. We said, let's keep the door open. So one thing is that we are all have as per the guidelines, they say we are not promoting it, but under supervision, you can do it. So coming down, I will skip to all this and come to my guidelines of monotherapy and combined therapy. And I will close at this. My guidelines are BT dosing for T3, for monotherapy in infertility and depression, combination therapy once a day may be enough, add it later. I prefer the 1:2 ratio. Don't be stuck on 1:4 or 1:3. I always prefer that you should have enough T3. Don't keep on adding T4 in those ratios. Use sustained release if you want to. Dose initiations and modulation take 3 to 6 months to take care of that. Autoimmune response well to T3. Over time, antibodies will come under control, and don't go by lab numbers, treat the patient, etc., etc. Don't push it. Lastly, if patient is skeptical or hesitant, leave them alone. Don't try to push it. Okay. Thank you very much. Hakuna Matata. And I'm done. Is there any questions? I can take it.
Yes, there are questions, Dr. Vivek, and thank you for sharing all these studies. They are always, always, always very helpful.
Okay,
so, Dr. Vivek, first question I have for you is, Shivani wants to know that how can FM health coaches use the mentoring of Dr. Vivek Kadambi to help their clients reevaluate their T4 thyroid medications?
So I can tell you that I'm happy to offer my services, but I'm a taskmaster and I'm very fussy about my students. I need discipline. I need people to be focused. So I will try, Priti, we did talk about this, that through IFM, let's make a course, and I'm happy to take my end of it if the entire course is built around me. Unfortunately, I've got so much into academics that I don't have the infrastructure or the bandwidth to actually organize these courses, though I do provide, but I have my limitations. So I would say the best way is that, Preeti, I'm open to any system that says that, please come, and I'm open to hand-holding for those students who are genuinely interested, and not for someone who wants to come fly by night. There's a lot of hard work that goes into it, understanding the fundamentals. So academics, I'm not able to manage the way I thought I could and have a nice program to hold it. But if anybody wants me to be a part of their program, I'd be very happy to do that. Or come from our Tuesday meetings, Tuesday morning meetings. If you come.
That was my next question, Dr. Vivek. So one is, of course, I will reconnect with you and plan a program for everybody. But second question was, if somebody is interested in joining the Tuesday meeting, is it all right that we share your number in the group and they can reach out to you and then you can assess and allow if you think that they can join? Or how would you want us to do it?
Yeah, so I'll do it like this. Preeti, it should come from you or Renuka. So if somebody just sends randomly, I will not. If something comes and says so-and-so person wants to join, I presume that's coming because I don't want a crowd. I want serious-minded people. Second is that a co-consult. If you have a patient and you want a consult of mine, okay, you can always contact my office and they will share my number to them. I'll be happy to co-consult with whatever information you give me. And I'll handhold you as best as I can. That's
I
best I
can
can say.
vouch for that, Dr. Vivek.
Okay.
Thank you. So, Renuka, two things for us. One is anybody who is interested in joining the Tuesday class, they can share their number and email ID with Renuka. Renuka will get Dr. Vivek's approval and, Dr. Vivek will add you to the podcast list. Right. And second, of course, for co-consult, Renuka, you can take Dr. Vivek's team member's number and you can share that. So anybody...
I will share my help desk number with you and you can share that with anybody who's interested.
Yes, perfect. Great. So that is a great add-on to everybody.
I like the chat group saying interested. I'm getting, I'm getting more interest here than my bank. my
great,
bank does.
Dr. Vivek. Nice. So, Dr. Vivek, and I think this question I can ask Dr. Anshul. Hello, Dr. Anshul. Happy to have you here.
Hello. Hi, Dr. Preeti.
Hi. Thank you. I heard that you were having some problem with your laptop.
Yeah, last moment my laptop decided that it doesn't want to charge anymore. So I have to struggle to borrow my wife's laptop. And
wow.
You know how it is that she has
technology is not that reliable.
Well, I know, yeah.
You borrowed your wife's laptop, now your laptop will start nagging you.
I know. I was dreading for that moment. Finally, I had to convince her to do it. And luckily she did lend me a laptop. So that worked out good.
So thank you to your wife also, Dr. Anshul, for, lending her laptop to you. So Dr. Anshul, the question here is, what kind of exercise best helps thyroid and hormonal balance?
Right. So, I mean, exercise is a big, broad topic, right? Because I think we have to understand that everybody's baseline of where they are starting is very important to understand, right? Like a marathon runner, for him or her to run a couple of miles a day is not a big thing. But a person, who doesn't walk or doesn't do any regular exercise, for that person, a couple of miles a day would be too much. So that's very important to understand where is your baseline and then start slow from there on. What we have seen is that for hormonal balancing and thyroid, going on an extreme exercise routine, especially of a cardio, can be very detrimental for their hormones. So a mix of cardio and strength training generally works really good for that. Now, we are in a culture of people are running marathons, people are just so, I will say, addicted at this point of time that they want to run 20 marathons in a year. Well, it's good to have that exercise, but the extreme running routines for those people definitely can disrupt their hormones. So I will say a mix of cardio and strength training would be the best way to go.
Very, very, very important point, Dr. Anshul. And I have had patients who come they have tears in their eyes when I tell them, slow down for 6 weeks, and then gradually we will build that system up. But it's good to hear this coming from you also. Dr. Vivek, there's this question Shivani wants to know. Issue when patients are coming, that they're coming with high T4 dosages and their symptoms are not improving. Now, do we reduce T4 first after supporting gut liver infections and then introduce T3, or change them to bioidentical immediately, or add T3 there? What is your protocol?
All right. My protocol may be different from someone who's beginning and starting. The point over here is first understand what's happening. So as you go higher protocol, and let's take the doses, 25, no problem. 50 micrograms, no problem. Now, once it goes to 100, 120, anybody who's taking more than 75 or 100 micrograms of T4, it will never give you better effects. The law of diminishing returns, and then it goes down. So as long as you're in the 25 and 50 category, that's all the T4 you need. In fact, I describe T4 as kadi patta. You go to a shop, you buy the vegetables and say, "Bhaiya, thoda kadi patta dal do." So that kadi patta is the T4. The T4 has to just be enough to give that, but your T3 does the job. Now, why is your T4 not doing the job? Because not getting converted to T3, and there's reverse T3 getting happening. So first, pull back on the T4. Now, this will surprise the patient. Doctor, I'm not feeling well, and you are asking me to bring it down. So the question is, how quickly can you bring this patient into the T3? So if you bring the patient down and then then you analyze it, and then it's up to you how you counsel the patient. I can't tell you how to counsel a patient, but the final goal is going to be you're going to switch this patient over to a T3 or a T4 combination. In my case, it happens very quickly because they're already primed and they come referred. In your particular case, I can teach you, help you, but it is the tricky part to tell the patient. If you can explain why the T4 is not effective, explain to that, and do it in the manner in which you think your practice protocols are. I should not be telling you how to run your practice, but I can give you guidelines. Thank you.
Thank you, Dr. Vivek. Dr. DARYL, yeah, if you can answer this question, do T3 cross blood-brain barrier?
Yes.
And second, if we are supplying T3, then aren't we making thyroid gland jobless?
First of all, we do give some patients micro doses of T3. It has got to do quite often when they are really exhausted. They need a little bit of extra T3 on top of the T3 we already give them. And we give it to them every 12 hours. As Dr. Vivek said, the half-life of T3 is very short. That's why we give it to them very microdose twice a day, every 12 hours. The second part of your question was?
Are we making thyroid jobless by giving T3?
Making thyroid?
Jobless.
Sorry, I don't understand the question.
Jobless.
Are we making the thyroid? Yeah, are we making the thyroid gland redundant? That we don't need thyroid gland anymore because we got it.
No. We only make up. This is where the thyroflex come in. We only make up the missing hormones. You're born, as we said before, this is a genetic problem, and you only make, say, 75% of the hormones that you need. Your thyroid naturally only makes that. We only replace the 25% that is missing. And that is determined by the reflex test.
Let me address the word jobless. You're right in saying this, but remember, you can call it jobless, you can call it lazy, or you can call it redundant. But here's the important thing. Let me be very candid about it. Yes. Once you give thyroid from the outside, you will see TSH levels going lower and lower and lower, and even the body will relax. But here's the very important thing: 80% of the patients with thyroid hypothyroidism have are Hashimoto's. You are actually giving rest to the thyroid so that the thyroiditis, which you can check with ultrasound, that you get where you are. And the reason is the moment you stop it. The moment you stop your T3, it catches up. So it's not that it becomes jobless. It's just that it is waiting in the sidelines and says, when I'm called 12th man, when you want me for the team, I'll come through. Sometimes you are not able to take that. So you're right in saying that the thyroid, especially if you look at those levels.
And I was sure that in my case
that's for straight hypo. I was talking about straight hypothyroidism. Hashimoto's, we have completely different protocol on.
Great.
Yeah.
Thank you, Dr. DARYL. Thank you, Dr. Vivek. Dr. ANSHUL, there's this question for you. I got diagnosed with Hashimoto's postpartum with TSH 154 and anti-TPO of more than 1,000. And I exclusively breastfed my child. My son is 4 years now, and his growth is slow. His height and weight is below 3rd percentile. Is it related to my Hashimoto's postpartum?
Well, so Hashimoto's or any thyroid disorders, as we were discussing, can be genetic. So that is the case. Now, the interesting part is that, like if you asked me this question 10 years ago, I would say that it is very rare to see Hashimoto's in kids. But now, almost every time, I'm just like people, all parents are reaching me out like 4 years, 5 years, 8 years.
4 years, yes. 2 days back, a 4-year-old child parent, reached out with Hashimoto's, and it's so sad. And generally, from his history, I could know mold is one of the triggering factors.
So the first question, the first part of the question was that, what to do, is there a concern about Hashimoto? So first of all, getting complete testing done. for Hashimoto's will be important for the child. So we know, because, as we will probably discuss a little bit later on also, the complete testing, and most people will just get the TSH, right? And not the complete testing. So very important to get the child tested for Hashimoto, so we know the complete picture. Now, the second question was that, is it related to the mom having Hashimoto's postpartum? So, I mean, a lot of moms are concerned that they might have given the disease to their child. So I just want to tell all the moms, it is not your fault. You cannot do anything to give something to your child. You're having Hashimoto's, yes, it is your journey. But having the child with these symptoms, it makes sense to get complete testing done, so you know what is going on with him or her.
Thank you, Dr. Anshul. Manjari, I want your opinion on this question. So Richa wants to know, my daughter is a type 1 diabetic with normal thyroid levels, but TPO antibodies in 200s. And we see it very, very often that type 1 diabetic patients develop Hashimoto's over a period of few months or years. The question here where I need your input is, Richa says that she has low stomach acid and nutritional deficiencies. She is working on herself, but what is it that she can do for her daughter? Maybe in terms of nutritional deficiencies and in terms of lifestyle, if you can help her address the situation.
Thank you, Dr. Preeti. Thank you for the question. And I mean, it's not an unknown fact that there is a huge amount of nutritional deficiency that causes primary and even autoimmune thyroiditis. There is obviously enough information there. The problem is that, when we look at, for example, she spoke of low stomach acid. The minute you have low stomach acid and your protease enzymes are not getting activated in the stomach and you don't start protein digestion in the stomach, there is a cascade of micronutrient deficiencies that will happen, because you're not even starting protein digestion. So people who have low stomach acid sometimes actually start using antacids, which is traditionally what is given in conventional medicine, which makes the condition even worse, because when you add an antacid to an already existing low acid in the stomach, you have done something counterproductive completely. So for anybody who has low stomach acid, although this is beyond the thyroid story, one of the things I'd like to say is not to take an antacid and actually take things to build acid in the stomach, So that was one of the things that will at least allow the nutritional, things to happen and the micronutrient deficiencies to become less pronounced. And as far as children are concerned, or the daughter is concerned, I mean, it's again a known case that the food that our children are eating today is nutritionally not as dense, plus their food choices tend to be slightly poorer. So if that is the case, I think sitting with the kid and understanding what the child is eating and where is it that, corrections can be done, so that we can at least close that gap of nutritional deficiency, which may be leading to at least primary hypothyroidism. So that can definitely be done.
Thank you, Manjari. But there's another question for you. How to improve ferritin levels if someone has gut issues?
Yeah, so So I think you already answered it. If I have gut issues and that's why my ferritin level is low, there is really not just, the idea is not just to pump in iron or take in the iron intravenously or in any other form. The first step would be to go back and correct the gut issue, and you address the gut, which is essentially from the food to the stressors, to the lifestyles, to if there is any toxins, excess antibiotics, whatever is causing the gut to be poor. First, you eliminate and you build up the gut lining. You have that 4R protocol, which is the gut repair protocol. And so I think the primary thing is for 3 months, get the person on a gut repair protocol. And then maybe, in the secondary stage, go to the.
Thank you. Also, what I have seen is these are the cases where parasitic infestations should definitely be checked, because they are the most common reason, at least in Indian population, where hemoglobin will come low, ferritin will come low. History of, heavy bleeding or something like that also needs to be ruled out. And a lot of other things should be taken into account. But as Manjari said,
Just one thing, because you mentioned, H. pylori, simple things like H. pylori, which are not even checked in people who have low ferritin and iron. Those things definitely need to be ruled out.
Thank you. So now there are a few more questions, but I will come back to them because I think I really am very, very interested in listening to what Dr. Anshul has to share with us. In the morning, Dr. Vivek and me, both of us said that 80% of the hypothyroid patients today have some form of antibodies, right? And Dr. Anshul is going to talk about Hashimoto's thyroid. And he's not going to educate us on Hashimoto's, but he's actually going to intuitively know what are the questions you have in your mind when you go to your conventional doctor and straight away directly answer those questions for you. Am I right, Dr. Anshul?
Yes, we'll try with kind of mind reading everybody's questions and answering them. Some of them obviously comes from the patients that we have seen for years and most common question that we get through.
Right. But before I give this opportunity to Dr. Anshul, I want to tell you that I met Dr. Anshul, I think Dr. Anshul 3 years back.
That's true.
And he had shifted from US to India in Jaipur. And before that, he was working at Cleveland Functional Medicine Clinic with Dr. Mark Hyman. And I happened to be listening to one of his interviews yesterday. Till then, I did not know his complete story, but I think that interview had about 25 minutes of him telling his story, how from conventional medicine he came into functional medicine. And that was pretty impressive. Dr. Anshul has written a book on Hashimoto's thyroid, which is the bestseller now. He's invested many, many, many hours in sharing all what he learned by treating so many patients, by working at Cleveland, then coming to India and working here with his patients, very, very generously there. I strongly recommend that if you're interested in knowing a little more on Hashimoto's, go on Amazon. Dr. Anshul, the book is on Amazon?
Yeah, that's correct. It's called Reversing Hashimoto's, so pretty simple title.
Great. And share the link also, Dr. Anshul, after this, and Renuka will share it with all the participants. Please click on the link, buy it, read it, and whatever effort he's invested in, I think we should spread the good word. He's recently got an award by Reader's Choice, just to confirm what I keep saying, that he's a great doctor. And it's a privilege to have him in my close circle of friends. Anytime I call him, even if he's very busy, he will call me back or pick up my call. Thank you, Dr. Anshul, for doing that. And for discussing some of the difficult cases with me. And also helping us take functional medicine forward in Indian community. I think people like you who have experience of working with Dr. Mark Hyman and now in India give a lot more confidence to our patients here that we are on the right track. And with Dr. Vivek always showing studies and Dr. DARYL bringing so many years of his experience. And Manjari, I think I will talk about her when I give her the opportunity, but thank you, Manjari, for being here. And Dr. Anshul, over to you now. You can hack everybody's mind and help us know what they are thinking and what is your answer to that.
Yeah, I'm probably changing my profession sometime soon, becoming a psychic, right? Jokes apart. So thank you so much for that generous introduction. And, we are all contributing to this field of functional medicine and obviously trying to help our patients. That's the bottom line. And giving them all the different ways and opportunities to contribute and improve their health. So I'm just going to share a quick presentation so that people can just follow me along. People can see my screen, right?
Yes.
Okay, awesome. Thank you. So yeah, so bottom line is that you're going to talk about Hashimoto's. And as I said, the goal is not to educate you on completely reversing Hashimoto's because that's a big project in itself. But just kind of telling you, why is it important to know about Hashimoto's and a lot of people are not even aware. So the research suggests that, if you have been diagnosed with a low thyroid or hypothyroid, there is a 90% chance that it is because of Hashimoto's. So that's a big number that, we are dealing with. The reason I'm sharing this number is that a lot of people have been told that they have low thyroid disorder, but they have never been checked for Hashimoto's disease. Now we have to understand there are two different things we are dealing with. One is a low thyroid issue, which is practically basically saying that your thyroid gland is not able to produce enough thyroid hormone. And Hashimoto's is actually an autoimmune condition where your body is actually making antibodies to destroy the thyroid gland, which ultimately leads to low thyroid or hypothyroid. So taking the medicine alone is not doing anything to address the autoimmune piece of it. So very important to understand that, you not only have to take the medicine or get the optimized hormone therapy through bioidentical hormones or T3 or T4. That's definitely one piece of it. But you also have to address the autoimmune piece of it so that you can safeguard your thyroid gland, because you can reduce inflammation in the body. Because as we were just discussing that once you have one autoimmune disease, there is a high chance that you can have a second autoimmune disease if you don't address the underlying problem with it. So that's the reason it is so impactful to know whether you have an autoimmune condition called Hashimoto's or not, right? Now, a lot of people, like as you were discussing, we want to also know about the Indian context, because a lot of people think, oh, well, I have never heard of Hashimoto's. I don't think I have Hashimoto's disease because this is a concept which is more prevalent in Western countries. Well, it is actually present in India. Now, the problem is that we do not have a population-wide study in India to actually know the prevalence of Hashimoto's. So very, very small study was done in 2009 by just evaluating 8 to 10,000 people and looking at the prevalence of Hashimoto's in those hypothyroid people. And this was a lower estimate that they did of at least minimum 50% would have Hashimoto's disease. So even with that, and this is a very conservative number. I think this is much more higher if you do a population-based study, like a bigger study. But even if you have 50% chances of having Hashimoto's disease, that is still a big number. So definitely Hashimoto's do exist in India. It is not an alien concept, or it is not like a Western concept. So that's again an important thing that, if you're living in India, make sure you're getting checked for Hashimoto's disease so you know whether you have autoimmunity or not. Now, this is where, as we were discussing, just answering that question about testing for Hashimoto's disease. Now, testing, is a very, very big topic in any kind of thyroid disorders. But especially in Hashimoto's disease, we need to do a complete testing, because most of the time the conventional doctors are only ordering a TSH test, right? Thyroid stimulating hormone. That is not a test to check for Hashimoto's disease. That is not even a test to check for complete thyroid profile to know how your thyroid is functioning. So that's the reason we have to know what kind of testing we need to get, right? And as we were talking about, like at this point of time, the patients have to be their own advocate to take their health into their own hands. I'm not saying conventional doctors are bad or they are not treating you properly. I'm a conventional doctor. Most of the people who are over here are conventional doctors. But the conventional doctors have not been trained completely, or their hands are tied because of certain situations in the current medical community. So that's the reason they're only ordering TSH, which is not the complete test, right? So that's the reason, first of all, we need to understand what is Hashimoto's disease. So as I said, Hashimoto's disease is an autoimmune disease. In that, most of the time, people will produce two different kinds of antibodies, okay? And these are directed against your thyroid tissues, and that leads to the destruction of the thyroid gland. So those antibodies needs to be checked to determine whether a person has Hashimoto's disease or not. Now, the interesting factor is that, these antibody levels can also determine how serious your Hashimoto's disease is. So it is not only important to know that, whether you have Hashimoto's or not, but these antibodies can also tell, how bad it is. So I just basically kind of, told people over here in terms of what all testing needs to be done, okay? So the first of all, we need to get TSH level done. Then we need to get the free T3, free T4 levels done. Now, whenever you are going to get a thyroid profile, most of the time Indian labs will share a complete thyroid profile, but that is total T4 and total T3, and not free T3 and T4. So like how Dr. Vivek shared that great slide on how different thyroid hormones are produced and how they are converted from TSH to what is T4 and what is T3 and stuff. It is also important to know, your free T4 and free T3 levels, because these are the actual free levels which are circulating in the body, which your body can utilize and can act on the body. So that's where it's very important. Now, reverse T3, like Dr. Vivek again touched on that very beautifully about this reverse T3. Most conventional doctors are not even aware of this reverse T3 that is being made in a person's body and how to check it. Now, as Dr. Vivek was already mentioning, the reverse T3 test is a little bit controversial test. The problem is that we do not have labs which are properly equipped to get the accurate results on the reverse T3. Even in United States, like most of the labs do not have a proper calibration machine, so that they are not sure that the levels they are giving are properly calibrated or not. And in India, this test is super expensive. So that's the reason, we don't order it very often. And but obviously, if you can get it, it's a good marker to know where your reverse T3 levels are, because a lot of time we are just pushing for T4 medicines or T3 medicines, but it might be the reverse.
Dr. Anshul, sorry to interrupt. You have said optimal levels more than 20 ng per ml. Is that a typo? Reverse T3 level?
It is a typo. I'm sorry. Yes, it
All
should
right.
be less than.
Okay, got
Yes.
it.
Yes.
Go ahead.
So that was the reverse T3. And then we are the two antibodies, which is the thyroglobulin antibodies and the TPO antibodies. So these are the two ones which are the most commonly checked antibodies for Hashimoto's disease. Now, what are these antibodies, right? What are the thyroglobulin antibodies or TPO antibodies? So thyroglobulin antibodies are basically antibodies which are made in the body against your thyroglobulin molecule. This is a molecule which is responsible, or which we utilize to make thyroid hormone. So thyroglobulin antibodies are basically directed against it. And that's what we see. TPO antibodies are against thyroid peroxidase enzyme. This is an enzyme, again, which is utilized to make thyroid hormone. And these antibodies are, again, the protein of that enzyme. And that's what these are most commonly detected. Now, over here, I've given the ranges and things. Now, again, the ranges of TSH or all of these things are very wide in terms of different labs will give you different ranges. Now, given these optimal ranges, these are kind of, very loosely based optimal ranges in kind of, you can say, functional medicine or integrative medicine world. These are not research backed, like all these ranges. So I just want to kind of put that disclaimer out there. Obviously, we have some researches in some of these levels, but we do not have complete research proving that these optimal levels should be reached. But I just gave it out there so people have just an idea of what they can shoot for in terms of their levels. Okay. And Dr. Vivek pointed out that the reverse T3 levels are the optimal levels should be opposite. So it should be less than 20. So I just want to make sure that people got that point over here. So that's the complete testing. So whenever you have a thyroid disorder, I think this should be a testing that you should do to make sure to know whether you have Hashimoto's disease or not. Now, what is Hashimoto's disease? If you have any of these two antibodies positive in your blood work, then that is diagnostic of Hashimoto's. Okay. So a lot of people have this question, will I have these antibodies? Do I have Hashimoto's or not? Yes. If the antibodies are higher than the reference range, yes, you do have Hashimoto's disease. Now you can do further testing. A lot of people will go for ultrasounds of the thyroid, or like biopsies or scans of thyroid diseases. Those are additional testing that can be done, but just the presence of antibodies do give you a diagnosis of Hashimoto's disease. Then the next question, obviously, like people have is that, why did I get Hashimoto's disease? Why did one day my body decided to produce antibodies against my own thyroid gland? Now, like any other autoimmune disease, we do not completely still understand autoimmunity. But most of the research points at this point of time that Hashimoto's or any other autoimmune disease is an interplay between your genetic makeup and the environmental triggers around us. Okay. So you can easily say it can also be considered as a lifestyle disease also, like diabetes or obesity or anything else, because it's an environment around us which leads to triggering of our genes that makes these antibodies. Okay, so there are two pieces. One is the genes, one is the environmental factors. Now we cannot do anything much with our genetic makeup. We cannot change this, at this point of time. Maybe in the future we might, but right now we can change the environmental factors. Okay, so that's the good news, that it's not a death sentence, because a lot of people have been told by their doctors, oh, well, you got the Hashimoto's disease, you cannot do anything, your thyroid is going to die, doesn't matter what you do. Okay. But, like obviously we have as functional medicine providers, we make protocols to lower these antibodies and obviously safeguard the thyroid. So that's the good news, that you can do things to lower the antibodies and safeguard your thyroid gland. Okay. So then what are these environmental factors, that ultimately leads to Hashimoto's? Because that's the next question people have, is that, well, what did I do? What happened to me? Why did I lead to Hashimoto's disease? So the problem is that we do not have a single answer. The conventional medicine, the model of care, actually originated when there was infectious diseases as the number one cause of death or morbidity, in all over the world. And the infectious disease are generally one cause factor. That means, you got a bacteria in your body that led to a particular infection like pneumonia or any other infection. Now, the new diseases we are dealing with, like cancer or autoimmunity, these are multifactorial. That means there is not single one factor, but there is a combination of factors which leads to this disease. So number one factor over here is food sensitivity. What that means is that, our body, because of the food, which is totally different from its original way it was produced. Now, because of genetic modifications and the different modern agricultural practices, adding a lot of chemicals and things, our food has changed. So our body is developing different kinds of food sensitivity against it. That means our body starts producing small amount of antibodies against the different parts of the food, whether it is a protein part of things. Most people will know about gluten. So these kind of food, our body produces antibodies, which ultimately can lead to destruction of the thyroid antibodies because of the destruction of the thyroid. The second one is nutritional deficiencies. There are a lot of vitamins and minerals that our body needs. Dr. Vivek again, showed that great slide about different kind of vitamins and minerals that is needed to produce a thyroid hormone. Our food itself is deficient into these vitamins and minerals. There was a research study done which compared the nutritional content of food from 1980s to 2010. And what they saw was that the food that we are growing right now has less amount of vitamins and minerals as compared to 1980s. So even though we are trying to eat healthy, we might not be getting the right nutrients which is needed by our thyroid to function properly. And that ultimately can lead to triggering of Hashimoto's disease. Then the next is toxins. Like our world today is becoming more and more toxic. Whether it is the heavy metals like lead or mercury, whether it is the air pollution we are dealing with, or whether we are dealing with mold toxins or other pesticides or insecticides, whole bunch of toxins that we are pouring into our environment. All of these toxins, again, hijack our immune system and leads to breakage of that immune system, and that again ultimately leads to Hashimoto's disease. Then there are infections, how we were discussing about H. pylori, or we were talking about parasites in the gut, or we were talking about like overgrowth of bacteria in the gut. We have Epstein-Barr virus infection. Even we are seeing an increased Hashimoto's incidence post-COVID. So all of these chronic infections can again lead to triggering of Hashimoto's because they can get reactivated in our body. And the last one is the stress or the trauma that we go through. We all deal with stress on the regular basis, but everybody has different thresholds of the stress. And we have research studies which shows that stress not only affects our body emotionally, but stress also affects our body physically. A research study was done which actually looked at people, which was called an A study, which was like adverse childhood events, that people who have Hashimoto's or any other autoimmune diseases, if they're exposed to trauma or stress when as a child, they had higher incidence of cancer, autoimmune diseases as an adult. So stress makes changes physically in your body, or trauma can do that too. So very important to know that. Now, again, I'm just going to share that information about where a particular person had this question that, postpartum, I was diagnosed with Hashimoto. Again, pregnancy and postpartum is a big stressor for females' body. Okay, because there are a lot of hormonal shifts which are happening, and we do see triggering of Hashimoto's disease very often after pregnancies. I'm not saying that a female should not get pregnant or that's a bad thing or pregnancy did it to you, but I'm just saying that pregnancy can be a big stressor on a female's body. We do see that can lead to triggering of Hashimoto's too. So these are all the root causes. Now, again, a lot of people will ask this question, well, what is my root cause? Tell me that one root cause. And people have to understand it is just not one root cause which is playing a role. It's a combination of 2 or 3 root causes coming together and leading to Hashimoto's disease. So the answer over here where people should be getting is that it is very important to work on all of these root causes.
Dr.
So
ANSHUL, 3 minutes more.
Sure. So that is very important to work on all the root causes so that you can get better. So I just want to kind of share this case study to give hope to people. This female, a 43-year-old, was diagnosed with hypothyroidism 4 years ago, was started on 50 micrograms of medicine, went up to 100. She had all the symptoms of Hashimoto's or thyroid. She was feeling tired all the time, brain fog, weight gain, constipation. The worst part was that even with this medicine, nothing was changing. She still had all the symptoms. So that's where she started working with us, what was going on. So first of all, we did testing for Hashimoto's. Her doctor never checked her for Hashimoto's, and obviously it was positive. So finally, okay, well, she had an autoimmune disease that we have to deal with. And then with further testing and things, we kind of came to know she had something called leaky gut, that she had deficiency of iron, B12, vitamins, and obviously toxins and things. A stepwise plan was made that included dietary changes, different kinds of supplements to address all of these above issues that we identified. Within 4 to 6 months, like 6 months later on, her TPO antibodies were initially 900, came down to only 80. Medicine dosage, we were able to reduce to 50 micrograms. The biggest part was that, she got her life back. She had a lot of energy in her body, brain fog went away, she had regular bowel movements, gut was feeling good, her mood was better, she had more stable mood. So she was just feeling that her life was ultimately back, that, was missing. So I think that's a very important message, that you can reverse your Hashimoto's, improve things if you just do simple things. Just want to leave with some take-home messages for people who want to kind of, from tomorrow itself, what they can do to improve their Hashimoto's diet. All right. So eat healthy, very important. In Indian context also, all these things are very, very applicable. A lot of Indian diets, are very heavily focused on carbohydrates or processed food. People, even they are not eating outside, they feel that their diet is really good. But a lot of times their diet is actually not nutritious. It is lacking good quality protein, lacking good quality fats and vegetables and things. So make sure you're focusing on that diet. And then we have supplements, which are always there. I just listed a few over here, which has great research studies that proves that they lower the antibody levels in Hashimoto's disease. Vitamin D, selenium, zinc, magnesium, L-tyrosine, omega-3s, all of them have good research studies which do support that, to do that. Trauma stress management, make sure you're working on that stress through meditation, deep breathing, or trauma work, by a therapist or a psychologist who is trained into that. Good quality sleep, with the mobile phones entering into our bedrooms, most people are sleeping like after 12 or 1 o'clock in the night, scrolling through the social media. No, we need 7-8 hours of sleep and good quality sleep. So all of these things are important. So I think this is the that you can do starting tomorrow itself, improving your diet. Supplements, I definitely should be, you should consult your doctor or a functional doctor before taking any supplements. So just to be, they know all their history. But stress management, adequate quality sleep, these are the basic things you can start doing today itself. And that will definitely help support your Hashimoto's healing journey. I just want to leave with that message over here so that people, understand that they can do things to improve their Hashimoto's and get better.
Thank you, Dr. ANSHUL, for actually answering a lot of questions which people have in their mind. But I have few more here which I will want, your inputs on. So the first question is where we get RT3 in India. Dr. Dan Patlab does it now. You can always reach out to them and they can help you. Dr. Anshul, you want to add to this?
Yeah, so absolutely, like, Dr. DARYL has already introduced that to do it. Some of the labs can do it. We're talking about T3 or reverse T3?
Reverse T3.
Right. So only few labs, across pan India will do it. I think, so you might have to call around and see. I don't do it very often because it's a very expensive test. I barely might have done it only once or twice. But I think Dr. DARYL has a thing he's bringing it.
Dr. Gupta, I've arranged for Dr. Dang's lab to do it nationwide in India.
Awesome.
RT3.
Yes.
The Dr. Lalpath lab also does for me RT3, but remember, most of them, the labs are sent abroad. They collect samples on certain days of the week or the first week of every month, and you have to wait for 7 to 10 days. It costs somewhere in the range of 10 to 12,000 rupees. But there are other labs also, but none of them do it in-house. They get it done from abroad.
Except for Dr. Dang's labs.
Yeah, so if
They
that
now do it in-house.
Yeah, if Dr. Dang's lab is available on a national, all over India through collection centers, that'd be great.
Yes, Dr. Vivek. So Dr. Dang, Arjun Dang is also a member of the Indian Association of Functional Medicine. And he is ready to support anybody who wants to use his lab for different tests. He has also introduced some more advanced functional medicine tests from not only from US, but from Australia and also different labs. So he's quite actively trying to support us whatever way he can.
Good.
If anybody wants, I will be happy to share your number with Dr. Arjun and he will then connect with you.
Do you know how much he charges?
I think 9K, but I'm not very sure, Dr. Vivek.
Okay.
No, the patient gets it done and I've never checked. But I will share the price after checking with Dr. Arjun.
All right.
Yeah. Thank you. So then the question is, so Manjari Sharma wants to know, does ANA test indicate possibility of Hashimoto's? Dr. Anshul?
Yeah, so the ANA test is a different antibody test that we are doing, which is the anti-nuclear antibody that is generally indicative of other autoimmune diseases. And it is a screening test. And then, there is a more specific ANA test that can be done to check for whether you have lupus, or Sjogren's or other diseases. ANA does reflect that you have an autoimmunity. It is not a specific test for Hashimoto's disease. If your ANA is positive, then yes, you can check for thyroid antibodies. And if those are positive, that do indicate that you have Hashimoto's.
Thank you, Dr. Anshul. So the next question is, iron deficiency, can that be a root cause for Hashimoto's? Dr. Vivek?
So when you look at iron deficiency as a cause, definitely, let me just talk in a term that you will understand, because you can't say iron and Hashimoto's. All autoimmune diseases, okay? All autoimmune diseases should be attacked. They occur in clusters. And therefore, when you're approaching one, if your person has Hashimoto's, you'll be quite sure. You can test a few others, antipyretrols, and you find they're positive. But the approach in functional medicine is always, the pyramidal approach. Your gut, you take care of the gut, you take care of vitamin D, take care of the iron also. Now, if it cannot, it's not 1:1 that you have iron deficiency and therefore your autoimmunity. But remember one thing, you will be careful. When the ferritin level climbs up and goes high ferritin levels may indicate inflammation. So don't get carried by ferritin. You have to do the whole profile. Now, one last very important part on autoimmunity. I hate these sort of answers that say we don't know the cause, because we know the cause. There is something called as autophagy. Autophagy, that concept won the Nobel Prize in 2016. Autophagy, I'm reading from one of the published ones, Tera hi tota kehta hai, is a protective and life-sustaining process in which cytoplasmic components are packed into double members, blah, blah, blah. It's a protective one. Now, any protective, just as inflammation is protective, autoimmunity is any protective function gone rogue. And therefore, it goes into that, then it causes inflammation, and there's a vicious cycle. So autophagy, like cancers, it's a part of a natural process which is supposed to protect you. It's got to get rid of the dead cells, but it goes rogue because of lack of other things, and then goes into autoimmunity. In functional medicine, that's the approach. So it's not that we don't know what causes autoimmune diseases. Important.
Thank you, Dr. Vivek. Dr. DARYL?
Yes.
Sneha wants to know if a woman was hypothyroid with TSH of 4.5 during her pregnancy, took medicine during pregnancy and continued post-delivery, and after 2 years, her TSH was 1.68, free T4 in normal range, but near to low optimal free T3. Now, is it a conversion issue or Hashimoto's? Is there a way to analyze even before looking into the antibodies panel? I think I will want you all three of
determine the
you to opine on
Hashimoto's
this
question.
case.
To determine the Hashimoto's question, she simply takes a antibodies test. We recommend is TPOAB and TGAB. We've now added that into a standard panel. Now we have the ability to test because I want to know what the RT3 is. We've already established through the previous speakers, that's Dr. Prudence Hall and Dr. Naomi early today, that you cannot read very much out of the standardized blood tests, be it TSH, which he's talking about, because according to Sir Dr. Richard Bayliss, head of the Endocrinology Society in Europe, none of the blood tests, that be as TSH, T3, T4, free T3, free T4, are valid for determining thyroid function. So if she wants to know if she has Hashimoto's, you have to do the actual antibodies test and also rule out reverse T3.
Perfect. Dr. Vivek, you want to add to what Dr. DARYL said?
Yeah, so it's I understand that simplest way you can do the test and get the answers, but sometimes your clinical sense is good to actually utilize here. Before pregnancy, 4.5. After delivery, I don't know what is doing pregnancy. After delivery comes to 1.68. Not likely to be Hashimoto's, because Hashimoto's classical, if you're going by TSH. So therefore, sometimes what happens with the limited data you have, you can say not likely. I can't say it's not possible that a swinging TSH. Now, I don't know whether treatment changed, many other things that happen. So if you just give this as an exercise, 4.5 before pregnancy, because in pregnancy, TSH naturally also will go up. The thyroid globulin will go up. So those changes happen. And after pregnancy, if it actually comes down to 1.68, etc., I would say not likely, but just do the test and you will know. And if I'm right, let me know. I'll be happy.
Perfect.
And I just want to add.
Sorry, Dr. DARYL, yes.
I just want to add one more thing. Symptomatically, one of the dead giveaways of whether a patient has Hashimoto's or not is palpitations, tachycardia. If she has palpitations or tachycardia, there's a there is a probability she has autoimmune.
Great. Dr. Anshul, you will want to add something here?
Well, I mean, obviously, I think we all have our own clinical experiences and things. I generally am a little bit of a lab person, so I will suggest getting the lab. That is the easiest way to do it.
Yes, I agree.
Just
thank you, Dr. Anshul. So
but I think I've seen fluctuating TSH, happening in Hashimoto's patients because it's an autoimmune condition. So whenever your inflammation pieces are high or low, that also can affect your TSH. Because
also remember, when you send the patient goes for any ultrasound. I just ask them in abdomen, pelvis, breast, just go and have the ultrasound of the thyroid also. It just takes a little bit more time. And the thyroiditis will actually tell you also of the grade of inflammation, because some labs, and you have to put everything together. But in this case, labs are accurate. So I don't
Thank you, Dr. Vivek. Yeah. I actually agree with you, Dr. Vivek, but definitely testing always gives you a full proof thing. But Dr. Anshul, what supplement dosage does one require for zinc, selenium, and L-tyrosine?
Well, the dosage again depends on person to person and what is their nutritional status. And again, what form of these supplements are we taking? Because the selenium, in supplements can come from different sources, like selenomethionine and a couple of others. Same with zinc, can come from zinc sulfate, or zinc glycinate and things. But typically, like the dosage that, most of the research studies for selenium shows is between 100 to 200 micrograms is a kind of a safe dosage for selenium. For zinc, the dosage is generally between anywhere from 30 to 60 milligrams of the zinc that can be used. L-tyrosine, we don't have a standardized dosing, and that is one of the things that some people will use, some people will not, but between 300 to 500 can be easily used for that also.
Thank you, Dr. Anshul. Another question for you only. For someone who has Hashimoto's and is low on iron, how to manage iron whenever the patient takes supplements, they vomit every time?
So I think, like if you are not able to tolerate the supplements, like your diet is obviously an important piece. We have iron rich foods. So as Dr. Manjari and I think you guys were discussing before is that, if your ferritin and iron is low, you need to work on your gut. Like why you're having the low iron issues, whether it is obviously heavy menstrual periods, whether it is, like parasites or anything else in the gut. So work on the gut, get good dietary advice and make sure you're having iron rich foods. Other ways of iron is obviously like getting IM shots and obviously IV iron too. So if your iron is really low and you even cannot do anything from the dietary perspective, then IVs are other options.
Yeah. May I add something?
Yes, Dr. DARYL.
If you have Hashimoto's autoimmune, the first place it goes to is the gut. So of course, if you're taking some types of supplements, your gut may not agree with it.
Thank you, Dr. DARYL. So, Manjari.
Yeah, just remember.
Yes, Dr.
Especially B12, some of them you can take sublingual. So I think that should not be a problem. And very rarely, you can sometimes even give thyroid through the sublingual route. So there is a preparation that we can do, but it's not very common. It's done very important cases where they can't take anything that for a short period of time. So the route of one advantage of compounding is you can go transdermal, you can do sublingual for specific cases, but not done.
Thank you, Dr. Manjari, vegetarians and hypothyroidism. Please throw some light on it.
Yeah, in fact, when I get a chance to speak, Dr. Preeti, I would like to present a small case which was a huge meta-analysis on how there is actually less incidence of all forms of thyroid disease, including primary hypothyroidism and Hashimoto's, in people who are vegetarian and eat plant-based diet.
Perfect. So we will wait, and I will request the audience also to wait. I think I will only take 5 more minutes and I'll hand it over to Manjari. So, okay. So I have hypothyroidism since I was 16 years old. Now I am 40, weighing 93 kgs and with 2 kids. Recently did an anti-TPO test and came to know levels of 400 plus. Means I have leaky gut issue. Can this be treated? What is the dietary requirement? Can IUD cause leaky gut? I have IUD since 3 years. Question for Dr. ANSHUL GUPTA.
Okay. So, I mean, you had thyroid disorders for a long time. So presence of antibodies obviously doesn't guarantee that you have a leaky gut, but yes, high likelihood that you do have a leaky gut. And that is, like as Dr. Vivek was also and Dr. DARYL was mentioning, that gut is where we start. So absolutely working on your leaky gut issues by improving your diet, all the things that, we all are discussing over here is important. Now, the second question is that can IUD lead to Hashimoto's disease or leaky gut issues? So certainly yes, because most of the IUDs, so first of all, depending on what kind of IUD do you have. So there is a copper containing IUDs and then there is hormonal IUDs that we have. Most of the hormonal IUDs which are using synthetic hormones. And we know that these synthetic hormones can disrupt, our female hormones and can overburden our immune system. So certainly that can be one of the major reasons that causes hormonal dysfunction and can lead to Hashimoto's disease. Even copper-containing IUDs, like this is a foreign body which are being introduced in a person's body, and there is a reaction against it. Again, they are safe. Again, I'm not saying that you should get your IUD removed tomorrow or nobody should get an IUD, but yes, in certain people that can be a trigger and that can be contributing to it. So again, discussing with your OBGYN, what are the reasons of the IUDs that you got it and what are your alternatives, I think would be a good place to start.
Perfect. So somebody has shared, Sanjeev has shared that Dr. Arjun Dang's Dr. Dan's lab charges 7,700 for reverse T3. So
Thank
I
you.
think that's a great thing, because then that looks to be doable, especially in cases where we really want to do reverse T3. Right? Great. I'll take this last question, and then I'll introduce Manjari and hand it over to her. How good is curcumin supplement with Hashimoto's and hypothyroid? Anybody who wants to answer this, please.
How good is?
Curcumin. Curcumin supplement.
It's excellent. I mean, as you say, you build up the vitamin D, omegas, antioxidants. Curcumin is the anti-inflammatory. So put all together, I would say that it will handle your inflammatory part. But if you're only going to go with curcumin, you'll be disappointed. It will not be the first choice for me.
Yeah.
Dr. Anshul, your thought? Sorry, Manjari.
No. To what Dr. Vivek said, so it is, of course, the anti-inflammatory part, and it has to be taken with a combination of, as he said, omega-3s, vitamin D and everything. But there is also the antiviral, anti-parasitic, antifungal action of curcumin if taken in a good dose. And because we know that parasitic viral infections are one of the reasons for autoimmunity, so it's also helpful there.
Right.
Yeah, so I mean, just kind of, I think curcumin is one of those things that anybody asks, is it good? I said, yeah, why not? Right? Literally, like, we have more than 1,000 research studies of curcumin or like turmeric in different kinds of diseases. So obviously, there's very less downside to using curcumin. So certainly you can do it. But, as Dr. Vivek and Dr. Manjari also mentioned, curcumin alone is not going to be the solution. Working on all of these things aspect.
I think nothing alone is the solution. It has to be
Right.
a holistic approach. You have to come full circle. And I'm sure all those who listened to my presentation, while I was telling how many things I did daily, I was myself surprised. It was me only who did it, but I think the result is very promising. So it's worth doing that effort. Perfect. So I will leave some of the other questions like this. Dr. Anshul, people asking for your details. They want to consult you. They want to co-consult with you. If you can share your details with Renuka, she will share it with the participants so that you can help people diagnose the disease, correct the disease. And of course, if somebody wants a co-consult, I don't know whether you do it or not, but just share with Renuka and she will circulate it.
Absolutely.
And yes, Manjari, happy to have you here.
Happy to be here. It's a pleasure completely.
Thank you. So this thyroid summit I had planned, when I had promised to myself that I will reverse my thyroid and get off medicines. Okay? Because I was very sick and tired of improving it and then dipping down and improving it and then dipping down, but always titrating my doses. And people who know me, जित पे आ जाते हैं तो अपनी भी नहीं सुनते, right? Okay? And that's what. And this is how this was planned. And just 2 days back, I realized this summit cannot be complete without a nutritionist or diet being discussed in the summit. So honestly speaking, it was not that immediately I thought I need a nutritionist, right? Or a diet consultant. And I wrote to Manjari, no. I actually looked at the group, every possible name, right? And then I graded everybody and said, Manjari is the only right person who who understands functional medicine beautifully. She works with Max as a nutrition consultant. She works with a lot of organizations, helping them focus on nutrition. She's also the director at Bonatra, where I am extremely motivated and inspired to see the amount of work she has put in there. She travels to Bangalore. Well, I think she was traveling every week. Now she travels every 2 weeks or 3 weeks. And the beauty is, she'll say, Dr. Preeti, I'm landing at 3 p.m., but I can meet you at 5 p.m. And I am like, wow, Manjari, this is amazing. So thank you, Manjari, for contributing so much to this functional medicine space, for giving us the confidence that we are doing right when it comes to diet and nutrition. And of course, I know you are going to share today from your heart so that every thyroid patient knows what to do tomorrow morning.
Thank you, Dr. Preeti. Those are very kind words, and inspired by everybody who's here. Look up to all of you, Dr. Vivek, Dr. DARYL, Dr. Anshul. It's a pleasure to be in your company. So I can request Renuka to put up the presentation because I'm very bad with technology. So yeah. Yeah, thank you.
I forgot to mention, she's written 2 books, Eat Up, Clean Up, and Heal with Foods. And I've read both of them. They're great books. Go on Amazon, click on the link, read them, and share your review.
Thank you. I'm in fact now writing the third one with Rupa Publications. It's on the gut-brain connection, and I'm hoping that I can make it very mainstream for people to read and not make it technical. So yeah, it's a pleasure being here. Let's go through the small presentation. We can skip to the next slide, please. And we can avoid this one because this has been discussed in detail. Let's go to the next one. So we know through the day, everybody's discussed about what affects thyroid function. Here, I only wanted to show about the nutritional bit of it. So there are nutrients that have a huge role in the thyroid function. And when you look at the pathways in which they work, there are multiple pathways that get affected. So the bioregulatory systems that are involved in the conversion of T4 to T3, and the fact that T3 and T4 are both competing for the same binding sites in the cell, that process also has some outlay in the nutritional status of the person who has any thyroid abnormality. So we know of nutrients, iron, iodine, zinc, selenium, magnesium, the vitamins, minerals, especially the B complex, vitamin D, vitamin E. All of these are very crucial for thyroid function. Zinc becomes even more crucial, and there's not much talk of it. Also with the fact that Indian diet, especially some of our food, has very little zinc to it. So let's go through how we can work on that. The next slide, please. So if you look at where these nutrients work, so the TSH requires protein, magnesium, zinc. So they become the things that are required for production of the stimulating hormone from the pituitary. And then, of course, you require iodine, vitamin C, and B2 for the thyroid to make enough amount of T4. And then the conversion of T4 to T3 requires selenium. It also requires a well-functioning adrenal gland, so no adrenal fatigue, and a good, healthy, clean liver. Yeah, do the next slide, please. So this is just a basic idea of what is happening with these. I'm looking at 5 nutrients now, mostly minerals and vitamins and inositol. So iodine required for T3, T4. You get it from iodized salt, but I would definitely not recommend table salt, which is iodized. It's always the other forms of salts, which is natural salt. The best one would, of course, be pink Himalayan salt, but Celtic salt, sea salt, even a little bit of rock salt and black salt are better ideas than taking white table salt, which is commercially iodized. Then there are certain foods that give iodine in good amount, especially seafoods, fish, some sea vegetables. Also, we know that kale is a good source of iodine. Some seaweeds, Japanese vegetables are a good source of iodine. Selenium is required for the, so it's basically the part of the cofactor for the enzymes where the T4 has to be converted into the active T3. We know that that's the biologically active form of the hormone. Now that conversion requires selenium. It is also required for the activation of T4 hormone in the same pathway. Most of the selenium that we get comes from the food that we can eat, comes from either fish and shellfish, but it also comes from some vegetables. Spinach is one of them, but other Indian green vegetables also have selenium in sufficient amounts. Some of the nuts have it. Brazil nuts are a very good source of selenium. Most of us already know that. The third one is iron. So iron is essentially required because the thyroid peroxidase enzyme, which is required for the thyroid hormone synthesis, the function of that is dependent on iron. And organ meats. We know that there's heme iron, there is non-heme iron. Vegetarian sources of iron are there, but it's not well absorbed. It's slightly poorly absorbed. Having said that, I do not mean to say that people who are vegetarians will have low iron levels if they have a well-functioning gut. But there are animal sources which are good sources. Besides that, nuts and seeds, these are also some good sources of iron, and of course, dark green vegetables. The problem is when you eat dark green vegetables, your body should be able to absorb the iron, and that pathway is mostly, a lot of people have that pathway compromised. The next one is zinc. As we discussed, zinc is again, the activity of thyroid peroxidase is one part of the zinc requirement. It is also required for when the thyroid hormone synthesis happens, the iodination of thyroglobulin. And it also becomes a part of the receptor function and signaling pathways, and its deficiency may change the receptor function or alter it, or sort of compromise on the signaling pathways for thyroid production, especially T3 activation. Zinc is found again especially in oysters, shellfish. That's a good source of zinc, but it's also found in vegetarian, a lot of plant-based foods. Millets are a good source of zinc, especially the smaller millets, the kodo millet, the barnyard, the proso millet. These are good sources of zinc. Besides that, seeds, especially pumpkin seeds, also Brazil nuts, flax seeds, and some of the pseudo grains, I would really not talk, are also a good source of zinc. Buckwheat is a very interesting source of zinc. It has a huge amount of zinc in it. So the buckwheat is another pseudo grain that we can eat. Vitamin D, we already know about the protective action of vitamin D against autoimmunity, and also the fact that there is a direct correlation between vitamin D deficiency and the development of Hashimoto's. So sadly, it's not easy to get enough amount of vitamin D, considering that most of us are indoors and don't get so much sun exposure. And so therefore, although some fish and eggs can give vitamin D, sunshine is the best source. But I think a lot of us would require vitamin D supplement, specifically a daily supplement, to make up for the vitamin D doses, at least initially, until the big gap is taken care of. Inositol, again, it's required for, one is, of course, the thyroid stimulating hormone. So reducing the TSH levels, that's one job that inositol can do. And then it also helps in reducing elevated antibodies, which are specifically part of the Hashimoto's, the TPO, anti-TPO, and the TG antibodies that we spoke of. Citrus fruits, a lot of dried raisins and dates and figs are is a good source of inositol. And now you have myo-inositol as a good supplement available, so that can be used if required. Just before we go ahead, I'd like to say that some of the people we see, especially with as Dr. ANSHUL and Dr. VIVEK already said, that 80% or more people who have thyroid actually have Hashimoto's. It's autoimmune thyroiditis. And therefore, when we sit with them, especially in the nutritional protocol, we do put them on supplementation, especially selenium, myo-inositol, zinc many times, and try and make up for the iron deficiency also. So iodine is a double-edged sword. We'll come and talk about the iodine going forward, but iodine also in some amount can be given for people who have either primary, although I've mentioned primary hypothyroidism, but the same thing extends to Hashimoto's also. Let's go to the next slide, please. A lot of people are worried about something called goitrogens. So, what is goitrogen? Essentially, it comes from endemic goiter, the word goiter, which is the enlargement of the thyroid gland. And it means that any substance, which could be a chemical or a compound or any other substrate of a bioregulatory mechanism that can block the thyroid function in the thyroid gland. And that substance is called a goitrogenic substance. And although theoretically, there are a lot of foods that contain goitrogen. So if you look at the list, for example, we all know that all cruciferous vegetables, brassica family, also certain nuts, certain vegetables, soy, of course, as a crop, also strawberries have high amount of goitrogenic compounds, or let's say, not negligible, but significant amount of goitrogenic compounds. But as far as the fact that these foods contain goitrogenic compounds and whether it affects thyroid function, those are two different stories altogether. There is a lot of research which shows that although these foods contain goitrogenic compounds, they don't directly affect or they don't block the thyroid function. So they really, the amount of goitrogen in these vegetables and other food sources is not significant enough to create the condition of blocking the thyroid function or being goitrogenic in the true sense in the human body. Also, the other bit is that when you cook most of these foods that we eat, we cook them. So when you cook them, especially when you boil or steam these vegetables and these foods, you are able to deactivate the goitrogenic compounds, and therefore they don't stay active anymore, and they do not affect thyroid function. The systems in which goitrogenic compounds work, if you look at it, some foods contain cyanogenic glucosides, so then they basically compete with iodine for the uptake by thyroid. Some cruciferous vegetables, most cruciferous vegetables contain glucosinolates. So these are basically metabolites which again compete with iodine for the thyroid uptake. And soy specifically and some millets have flavonoids. And these flavonoids being active, part of they do impair thyroid peroxidase activity, which is required for T3 activation. So in theory, let me repeat, in theory, there are foods that have goitrogens, which may theoretically be capable of blocking thyroid function, but the amount of research and clinical work that has gone into it, there is really no clinical presentation of goitrogenic activity of these foods normally in patients, even for people with an active thyroid condition. And I'm not even talking about normal people. I'm talking about people who already have a compromised thyroid function. Yeah. Next one, please. So gut, we've already spoken about the gut. This is just to tell you how, the gut health can affect your thyroid function or can impact thyroid both at the hypothyroid bit and at the autoimmune bit. So the gut microbiota, of course, are, we know that 70-80% of the immune system lies in our gut. So because they regulate the immune system, if there is a gut dysbiosis, if there is poor gut microbiome, then it'll affect immune function, eventually causing an autoimmune condition. Also, also, this is also actually outlined by the fact that when we introduce probiotics and micronutrients that repair not just the gut lining and help us in toning down the leaky gut, but also improve gut microbiome, there is always a positive effect of that, which means that the presentation of the disease becomes less pronounced. The thyroid, if you look at the blood work, the antibodies start becoming lesser. So that also goes to show that whenever you correct dysbiosis or you address leaky gut, you will end up addressing thyroid malfunction in both forms. Yeah, let's go to the next one. The other bit that I quickly wanted to talk about is obesity or excess fat, percentage body fat, especially visceral fat. So whenever there is a lot of visceral fat, and a lot of people do not know that they may look lean or thin on the outside, they may have something called visceral fat. So they may be in the TOFI category, they may look thin outside, but they may have fat in and around their organs in the visceral cavity and abdominal cavity. Now that fat because it is not only inflammatory, it also causes more oxidation and oxidative stress. It also, so there are various pathways in which the lipotoxicity affects thyroid function. Also because, visceral fat can cause, or stored fat inside our abdomen, around our organs or in the organs, can cause changes in multiple other mechanisms, primarily insulin behavior in the body. So that also, because it leads to a poor quality liver. We know that we need a clean liver for the T4 to be converted into T3. So the minute a person has excess body fat or percentage body fat or visceral body fat, it will be one of the reasons for having thyroid, especially a hypothyroid condition, and through various pathways, through the oxidative pathway, through toxicity, lipotoxicity, through a fatty liver, through inflammation, through the way insulin is behaving in the body. Also, of course, adrenal function will get affected with excess body fat. Next, the last slide. So these are just small things, nuggets that I wanted to put in. Of course, we know that nutritional intervention helps. Healing the gut helps, reducing inflammation helps, losing weight helps. So all of it helps in managing and treating thyroid disease. But these are certain things that have been very radically proved by science. So personalized intervention, when we are looking at anti-inflammatory nutritional protocol, specific nutrients, and on interventions that cause biotransformation, whether it is, again, the transformation in reducing inflammation or improving gut microbiome, we are helping in restoring the thyroid hormone balance. Of course, adequate intake of micronutrients, and a lot of people do not even know that they are low on iron or iodine or selenium or zinc or vitamin D, which is a lot of people not even know, and some of them, of course, know, but haven't done enough to correct it. So correcting that is of primary importance when you look at the nutritional intervention for managing thyroid disease. Besides that, of course, botanical supplements through botanical herbs and certain active components can also be used. Ashwagandha has been studied heavily, and there's a lot of information available about how ashwagandha is able to be used as a complementary treatment for thyroid. Balancing gut health, a good microbial landscape, which is primarily important. Not only it affects many other systems of body, it also is hundreds and thousands of studies show the concurrently reporting of gut dysbiosis with autoimmune thyroiditis. Some pollutants, especially the pollutants that are present in our environment, dioxins, the PCBs, bisphenols, all of these things that are very commonly now found in especially in our fish, meat, egg, dairy, are also one of the reasons for poorly functioning thyroid, and they do have anti-thyroid effects. So for people who have thyroid, we also request them to eliminate, foods which tend to be higher in these environmental pollutants, especially the PCBs, the bisphenols, dioxins. This is something I wanted to talk about. So if you look at the last point here, there's been a lot of study on comparing hypothyroidism, and I'm talking about primary hypothyroidism now, in between omnivores, in vegetarians and vegan population. And it has been, and most studies have concluded and have to some extent come to statistical conclusion that hypothyroidism is a little less common, in fact, significantly less common in people who tend to be relying mostly on plants for their food. Of course, this sort of contradicts with the fact that certain nutrients like zinc and iron are found primarily in animal sources. But the fact that plant-based food gives us high amount of antioxidants, polyphenols, keeps our inflammation low, is far more healing for the body, allows the whole environment to be more feasible and more favorable for thyroid function. So that's, it's not just studies, there's enough anecdotal reference, there's enough clinical work that we do where we see that when people move to plant-based diets, their thyroid functions become better, their TSH levels start improving. And the last bit that I wanted to talk about is really the animal fat bit. So so there has been, again, there's a lot of work around consumption of animal fats and their association with the antibodies, so whether it's TPO or TG antibodies, whichever studies have been done, they show that consumption of animal fats causes higher numbers in terms of elevation of the peroxidase and the thyroglobulin antibodies. So that's another one. That's why, fats that are derived from plants, not seed oils, but things like olive oil, completely extra virgin, avocado, flaxseed, coconut, and good quality cold pressed mustard oil, and nuts and seeds. Those types of fats are more favorable for the functioning of the thyroid gland. Yeah, thank you. That was from my side. I wanted to keep it short and simple.
Perfect. You've taken exactly 20 minutes, Manjari. Thank you for being so much on time. And we have a lot of questions. So do you recommend the AIP diet for Hashimoto's management, Manjari?
Yeah, so because Hashimoto's is an autoimmune thyroiditis, the autoimmune protocol works very well for it, because our autoimmune protocol is highly restrictive and it becomes a little difficult to follow. So we sit with people and work it around in a way that it's easy for them to follow. However, it has to be done for at least 6 to 12 weeks, depending on what the starting point is, and it shows very good results. So the AIP is definitely recommended.
Thank you. Dr. Anshul, there's a question people want to know, can Ayurvedic supplements lead to Hashimoto's?
I think that's a very controversial question, and I should be not answering that.
Especially given to you, Dr. Anshul.
So the Ayurvedic supplements are great, right? In terms of the Ayurvedic medicine, we know that can be very, very helpful for treating a lot of diseases. The only concern being that, we have seen that a lot of the Ayurvedic supplements are not being tested for heavy metals, like lead, mercury, and also like different kinds of chemicals. So I have seen people, getting toxic on these supplements sometimes with the lead, especially if they're not being checked.
Yes.
So when you're working with a company or taking an Ayurvedic supplement, just ask them, whether they're checking it for that or using companies which already do it would be a way of going forward.
Very nicely put, Dr. Anshul, that I think we need to be aware. And reading the food label is very, very important exercise, which we all should start doing if we are not doing it.
I would like to say something on reading the food label. Why even bother about reading the food label? Why even eat food that has label to it? The idea is to really get back to eating food which is real food and doesn't need to have a nutritional label attached to it.
Perfect.
Right.
So on this, Manjari, there's a question for you. What are the natural probiotics which you will recommend for thyroid patients to consume?
So, Dr. Preeti, there's a word of caution here for people who want to get into a probiotic protocol. It's not a good idea to directly start probiotics right away, because if you have gut dysbiosis, you're basically giving food to your poor gut, your pathogenic bacteria. So that's why whenever we look at probiotics and introduction, we initially look at removing first, repairing, and then re-inoculating with the right probiotics. So it's also important to remove the bad guys and then start the probiotics. A lot of people think they can just keep popping a probiotic and that will help.
They're just messing with themselves. Right. But if in the third stage also, Manjari, we need to include, what are the few probiotics which you will recommend?
Yeah. So certain, of course, sometimes we need targeted probiotics. So sometimes we use very simple ones like the Econom, Sporlac, basic probiotics. Of course, there are now good probiotics. You have pre-probiotics, symbiotics, all forms of probiotics. So use case may require a specific probiotic, but the beauty is you can get it a lot from food. And in food in India, we typically ferment food. So if you're allowed to eat a grain or rice, you can start fermenting that and use resistant starch also as a pre and a probiotic. Besides that, everything that you can possibly ferment, from vegetables to meat, whatever you can ferment and eat and has live bacteria in it. So from kimchi, sauerkraut, kombucha, also the pickles that we make at home. One of the things that we have stopped doing is making our own vegetables into pickles, which was an easy way of getting probiotics. So pickled vegetables, and of course, simple things like apple cider vinegar, good quality with the mother. All these are very effective probiotics.
Thank you, Manjari.
I'd like to add something to that, Dr.
Yes,
Preeti.
Dr. Vivek.
One of the things we should get out of is getting used to drinking quote unquote sterile RO water. We should get in these organisms. Therefore, it's basically not just the food. We have to start making changes in the way we drink the water. Of course, I'm sure, Manjari, if you can explain better as to what is healthy water versus clean water, it would be useful. But that's the second poison. One of the important poisons that today we are all consuming is all of us getting to RO, reverse osmosis water. And I'd like to see change there.
Thanks for bringing that up, Dr. Vivek. And I've actually been researching into water now for almost more than a year. And I feel we are all 70% plus water, and that should be looked into. And we will definitely have this discussion in the next goal. I have this patient about whom somebody is wanting. So before that, ashwagandha dosage, do you think there are some limitations? Dr. Vivek, will you want to answer what is the dosage in which you want to prescribe for thyroid patients?
I don't think there's any limitations. In any case, I'm not an expert on the Ayurvedic part of ashwagandha. And I don't myself get into the prescription part. However, many of my patients are on ashwagandha, and I leave it to their doctors to do it. I don't believe, frankly, that there is a problem. The only problem with ashwagandha is that, are you getting the ashwagandha? Because I'm involved in a company that deals with the raw material, and to get good quality ashwagandha, which is from the Himalayan belt and not from the roots and not the other components, is very expensive. So when you take ashwagandha, if you're price sensitive, you're going to get really nothing out of that. So I can't recommend any of those ashwagandhas that are easily available. But I do know that certain not so well known Ayurvedic organizations, they provide good ashwagandha. The cost is always a limiting factor for good quality ashwagandha. That's the best I can say.
For any supplement, I think cost is a factor, but we must balance out what we are taking.
But I'm quite sure there's no upper end, there's no downside to taking more ashwagandha.
Right.
At least I'm not aware of.
Some patients don't respond to ashwagandha well because it's a nightshade vegetable, but there are very few, maybe 10-15%. And if the patient does not respond well, then we always have that option of stopping it.
Yeah.
But otherwise, I think ashwagandha plays a good role in helping patients.
So there was a time about 10-15 years ago when we had our own ashwagandha, DARYL, our own supplements. And I just decided that now I want to focus on the hormones. Gradually, I got out of that. That's a different way of marketing, the different vertical altogether. We should not try to do everything.
No, we can't.
I sort of one by one, we discontinued that. And we...
Dr. Anshul, I think this will be the last question because then we'll have to wind up. What is your take on FODMAP diet as it leads to severe nutrient deficiencies?
So FODMAP diet is typically used people who have SIBO, which is a small intestinal bacterial overgrowth. It is kind of thought that, those high FODMAP foods, feeds the bad bacteria, and that ultimately leads to the symptoms of SIBO, of bloating and uncomfort feeling. Now, FODMAP diet is a limiting diet because it does limit a lot of different foods. So it's a very restrictive diet. Now, the FODMAP diet typically was actually made for being done for a short amount of time, for let's say 6 weeks or 8 weeks or a couple of months or so. A lot of people have been doing that diet as a new diet, like people have been doing it for years. So I think whenever a restrictive diet is done for years, then that can definitely create nutritional deficiencies or even patterns of food issues. So that's where, like, I think we have to understand that every diet has a role and there is a place for it. But that doesn't mean that, that particular diet can be used on long-term basis. So I'm not in favor of using a FODMAP for a long-term basis, but I think for short-term basis for treating SIBO.
Thank you all the panelists for sharing such vital information. I'm sure everybody got a lot of to-do Monday morning things. Right. And thank you, Dr. Anshul, for reading everybody's mind so well. It was really nice. Dr. DARYL, please have somebody share the list of centers where Thyroflex machine is available. So that if anybody is interested, they can, go and check their thyroid. And thanks for your support in doing the summit. Thank you, everybody. And over to you, Dr. Ashwini.